Good morning, Dr. Shoba. Thank you so much for having a chat, for us being able to have this conversation today. I think that's one thing that I've really missed throughout this whole pandemic, is just being able to have that collegiate sort of discussion with other colleagues about what we're seeing and what we've noticed. So I'm so grateful for your time and that we can have this chat together. So maybe tell me a little bit more about yourself and your background. You're a geriatrician from South Australia.
Correct, Melissa. It's good to be on. Thank you very much for taking the time to do this podcast with me. Once again, I've also missed having the discussions with colleagues. As we'll say a bit later, it's just been hard to have an open discussion about this topic. So yes, I'm from South Australia. I graduated from the University of Adelaide in 1997. I did a few years of physician training. I became a geriatrician in around 2006, 2007. I worked in public hospitals for most of my career. And over the last 10 years, I've been in full-time private practice in geriatrics. Mm-hmm. So I have a clinic once or twice a week, and I also have a telehealth with nursing homes.
That's probably such an important perspective to come through from all of this, because our older patients were most at risk from COVID. And so you would have had a lot of experience and knowledge of these patients and a long history with them to sort of observe the impacts of the pandemic and then the impacts of the vaccination program. So you're really coming from a position of a lot of experience and knowledge in this area. And so when did you first start to think something's not right here, like I'm just, not happy with how things are progressing throughout the pandemic, or when you had concerns about how everything was progressing?
Yes, so it's now like 3.5 years. So it's going back a while, since 2020. So in 2020, it was all a novelty. I've never in my career, nothing like this had ever happened before, lockdowns and this threat of this new virus that had come. So initially it was a novelty, doing phone consultations in 2020. A lot of people cancelled the appointments with the fear. A lot of patients were scared in the waiting room of getting COVID. So a lot of them didn't come into my surgery during 2020. So during 2020, I thought this is a little unusual, but I went along with it. Then in 2021, we in South Australia didn't have that many lockdowns, but I observed in Melbourne and Sydney the harsh lockdowns and then the threat that they had to get vaccinated before they could open up the economy. And I started to think something was wrong because of that forced pressure. So around mid-2021, I felt a lot of things were wrong. And then around July, August 2021, a lot of patients came to me and said they'd have been having adverse effects. Some patients told me, and then I started noticing a lot of adverse effects, which I'll go into detail a little later. That's around the time I started noticing something was wrong and how much sicker the patients seemed to be that I was treating. A lot of them declined, their health deteriorated, and a lot of them developed a lot of other medical conditions, which we'll talk about shortly. So around 2021, I noticed things were going pear-shaped, I thought. And then in 2022, we had the excess debt rate starting. I think that's when I started to notice it, around mid-2022, and it's carried on to 2023. So all of these things, it's not just one event in particular, but the events over the last 3 years, I've been noticing a lot has been going wrong.
That's so interesting to hear that. Such a similar experience to what I observed and what I experienced. So up here in North Queensland, we also didn't have, the lockdowns were not onerous, but then I had family members, friends, patients who were describing what had happened in Victoria, which was just a horror. And at that stage, I was sort of thinking, look, this is, how are we balancing the benefits and risks of all of these various interventions? Because it's one thing to lock down and protect everyone from COVID, but then who's examining the impacts on mental health? Who's examining the risks and the downsides of having people die alone and not be able to be with their loved ones, even in palliative care and things like that? So that's so interesting. I would say I had very much similar experience coming in before the vaccine program. And then I found exactly the same thing as what you said. It was sort of about mid to end 21 where people started reporting events, and then into sort of early 22 in Queensland, our vaccination mandates came in, I think it was the 19th of December, where it was extremely widespread that almost every industry, you virtually all patients really had to have a vaccine to be able to live a normal life in some ways. And so then early 22 started to see a lot more adverse events. So what were the types of adverse events that you saw?
Yes, so I'd actually written a long list of adverse events which I'd seen. So there was a lot of categories of adverse events, and there was an acute reaction that I'd seen, which we discussed before, and I discussed another podcast. It was a 78-year-old man who, a day after having the AstraZeneca injection, had acute weakness afterwards, and he's had time in rehab. He's had a lot of investigations, but his weakness can't really be reversed, whatever we do. So that was the one that had the most effect on me, the one that reaction made me want to speak out. Because when he went to the Royal Adelaide Hospital, where he was admitted for a few weeks, nothing was mentioned in the discharge summary that he had the injection the day before the weakness. It had a very long 17-page discharge summary. And from his reports and his family reports, the way he was treated by the doctors in the hospital, they didn't really want to acknowledge that it was related to the vaccine, because it couldn't be much else. It was 24 hours afterwards that he had the weakness. And he did have other health issues, but he was acutely worse since the vaccination. And he's now in a nursing home in Adelaide. So, it's been really hard. It's been from specialist to specialist trying to find a reason, and nothing specific. He's got a few causes which he had before the vaccination, but he's a lot worse. So he's someone that's,
stands out.
That stands out because of the acuteness, the reaction, and the way he was treated by the medical profession. The other reactions are in categories. One of them is damage to the blood vessels. So 3 of my patients, who were met during 2021, 2022, had strokes within weeks of the injection. Within 2 weeks. And the patients knew, they were saying they were well fit, someone in his 70s. 2 weeks after he had the AstraZeneca injection, he had stroke with weakness and speech deficits. He's now made a recovery. 2 patients had pulmonary emboli, which are clots to the lung. And I haven't seen myocarditis myself because it's usually in young men. I have seen heart failure after the injection. The other category was damage to the immune system. So 2 of my patients had recurrence of their cancer when the cancer was previously in remission for a decade or more than a decade. Some patients presenting very late with metastatic cancer that happened this year. And 2 patients that I know developed new cancers. The other things in the damage to the immune system category were autoimmune diseases. So one patient, which stands out in my mind as well, had in his 60s, had night sweats, muscle pains in late 2021, 2 to 4 weeks after the vaccination, the first dose, AstraZeneca, back in 2021. And initially they thought he had a lymphoma or some sort of malignancy, and then he had a lot of tests. In the end, he's got lung fibrosis and vasculitis, which is damaged the blood vessels. And he hasn't done very well. So his lung fibrosis has progressed a lot over the last year that I've known him. So another patient had polymyalgia rheumatica, which is a disease, autoimmune inflammation of the muscles and tissues of the body. Other things I've noticed, patients' immune systems appeared to be damaged. They got COVID several times. Some people had long COVID. Patients are frequently ill with respiratory infections is something else I've noticed. So the other categories are the existing conditions were often exacerbated. Conditions such as Parkinson's disease and heart failure, when we previously were stable with the medications, a few months or 1 or 2 months after the vaccination, they'd have a lot of deterioration, often severe enough to need hospitalization. But the biggest category I've seen is neurological conditions. So one thing that sticks out is unusual looking tremors. So, usually tremors are in your hands or your lower limbs. We think of Parkinson's disease. One patient I know had an unusual looking shoulder tremor, which one-sided shoulder tremor, which no one could really figure out. Very common neurological is headaches and dizziness, and unusual types of headaches which don't respond to standard migraine medications. Some people say they have the pressure, this beating in the head, according to one patient. And they do acknowledge, for people who think that it's a coincidence, that this started a short time after vaccination. I've also seen new cases of Parkinson's disease, several of them. New cases of Lewy body dementia, where patient's family said the symptoms started in 2021. Unusual pain syndromes, like burning pain over the whole face, unusual distribution of pain. And some of these patients were severe enough to need to go to the ED and needing opioids for a period of time. And the interesting thing about these unusual pain syndromes is their conventional investigations, CT, MRI, don't often show any noticeable abnormalities or no concerning abnormalities. So there's really no explanation. Sometimes they settle down and sometimes the pains persist. One of the biggest things I've noticed is cognitive decline. So patients who, to me, would say they were previously sharp for 2021. Now, often these patients are not linking it to the injections, but a number of my patients have said they were really sharp as a tack for 2021, and after the injections, they had deteriorated. So, and now it's 2.5 years since the vaccination started in Australia. And what I'm noticing long term in the specialty that I am in is an explosion of cases of dementia. So I was doing anywhere from 4 clinics a week back in 2021, but I had to cut down my hours because it was so exhausting. So earlier this year, I was doing 1 clinic a week to see patients, but I had so many referrals of cognitive decline that I opened up another half day of clinic practicing. And even then, I had a wait list of about 6 weeks, even with opening up an extra day just for new patients. So that's what I'm seeing. And so there's new cases of cognitive decline, and patients who previously had stable cognitive impairment or had memory loss, but they were early stages, declined very quickly. So in a short time frame of 3 months, they would decline, their scores in the mini-mental would decline like 6-7 points. So those are the sort of things. So the main long-term sequelae I'm noticing are the dementia, increase in dementia cases. And that's my area of interest, memory problems, treatment of dementia, being a geriatrician. That's what I'm noticing most.
Wow, I think every single one of those things that you just mentioned, I've also seen in the similar pattern to what you've described soon after vaccines, across that spectrum of neurological, vascular events, clotting events, and cancers as well, and long-term events, lung events. I mean, Shoba, you've just done amazing to listen to your patients. You've obviously put some thought into recognizing the patterns that you've seen, which is precisely our job as doctors, because patients aren't going to come in and say necessarily even going to link it to the vaccine themselves, because there's just been such an overwhelming messaging that the vaccines are safe and effective. So when somebody has a new event, they're not even necessarily going to be blaming that on the vaccine. That's our job and the job of the regulators to look for those patterns and document what we're seeing and report. And I mean, you've obviously done that in a very thoughtful and thorough and scientific way and collected this information. What do you think is stopping many other doctors from doing the same? Because I've had patients report the same thing to me, that it wasn't mentioned in their discharge summary, or a doctor wasn't willing to discuss the possibility that it might be related to vaccine. And I've heard that so many times from so many patients now, that it seems there's almost been like a real systemic reluctance amongst doctors to discuss what is just black and white. Part of our job is monitoring for adverse events, particularly with a new medication that's under the Black Triangle scheme. So what do you think is behind that I guess, reluctance to assign causality and to be open about some of these new events in a new medication?
I think one word is fear.
Mm.
So fear is the main issue. The other thing is, as doctors, we tend to sort of stick with the conventional messaging. We don't want to contradict public health messaging because we think it's for our own good. So we don't want to go against what, and it's also very hard to get proof that it is the vaccine as well. So I've described all the things I've seen, but another doctor will say that could all be coincidental. What troubles me is that how much more I'm seeing 2022, 2023 compared to other years. So I know what an average year in my practice looks like. I know what a very busy year looks like. So that is what I'm comparing it with. So to answer your question, it's fear, because there was several things. First of all, there was that March 2021 statement by APRA that we shouldn't do anything to undermine the COVID vaccination program. So that had a big impact on a lot of doctors. The other thing is, some of the doctors that had spoken out, not even publicly like we're doing, but even social media posts, liking something, they've got into trouble. So, doctors look after your families. You don't want to rock the boat. You don't want to get into trouble. So that's a big fear of getting suspended, because it has happened. We've had, complaints. Doctors have been complained about. They've been complained about misinformation. So it's this sort of fear. And also there's no open discussion that I'm seeing this. I haven't been able to tell many people. I've only stuck to my circle of doctor friends who think similarly. So it's that. So I think that's what one of the doctors is saying, you live in your own silos. So you think, well, maybe I'm the only one noticing these things, so you don't speak out. So fear, not speaking, not wanting to feel alienated, feeling a bit isolated with what you're seeing. And also the times that I do discuss it, or the times that I bring it up, like I'm on the phone with a doctor saying this patient had an adverse reaction to the injection, or I think it was, there's a silence. So this is not actually encouraged. So the discussion is immediately shut down. No one wants to continue it. And that's, once again, the fear. So that's my thoughts. But I was also troubled because it's getting to the point where it's really hard to hide. So many patients, when you talk to them, they say they had, after the second vaccine, they had a stroke, heart attack, some other event, or even if it's something that resolved over time, like they had a migraine or they had a TIA. There's so much, it's really hard to ignore. But then there's very troubling, the silence with such a big event.
Yeah.
So I don't exactly know the reasons, but I think fear is a really big part of it. And even patients would say, the doctor did say, oh, well, the stroke they think it's related to the injection, but I'm only going to say this off the record.
Yes.
So a lot of them have that. So it's a bit disappointing, but I think more doctors are speaking out now, like you were saying earlier.
Yeah, I agree. That's kind of the conclusion I think I've come to as well. I think an enormous amount of it is fear. And I completely agree with you. That statement from APRA, I'm sure it was an unintended consequence of that statement, but what it has meant is that doctors have not been openly discussing this, which, if you just take a step back and think about it logically, that's it's a ludicrous thing that we've all taken on that fear, because we're not speaking in a way that's like contrary to the principle of vaccination, or I guess the principles of public health, or protection of the public, but it's about a pharmaceutical product that is having adverse events and safety issues that we're seeing, which is, part of our job. But there has been a very real fear. I've even seen examples where, patients have taken on that fear. Like I've seen people, one patient that comes to mind, had transverse myelitis, and I saw this patient sometime afterwards, maybe 8 or 9 months afterwards, and I hadn't known about their admission for this, and I asked a few questions about it, and of course it had happened around sort of January of 22. So I wondered, and of course transverse myelitis is commonly associated with vaccines, probably more than any other cause for it. And I said, oh, did they give you a reason for it? And he sort of seemed quite fearful even in answering that. And he said, oh, no, they couldn't they couldn't think out what it was. And I said, oh, did you have a virus? Did you get an infection beforehand? No, I was totally well. It just happened, one day. I said, oh, did it happen after a vaccine? And he looked like he was going to pass out. He was like, we're not allowed to talk. I don't want to get you into trouble. Like, I know that we're not allowed to talk about that. And I said, oh, no, it's our job to, like, did it happen after? And he's like, oh yeah, well, I tried to raise that with the doctors, that it had been, 2 days beforehand I had a vaccine. Could it have been that? And he said that the reactions from doctors were anywhere between completely just shutting it down, walking away, not wanting to speak about it, or sort of aggressively defending the vaccine, or suggesting to him that, of course, there was no possibility that was the case. And said, oh, there was one nurse who sort of quietly came up to me and said, yeah, perhaps it is that does happen after vaccines. And what he said was that it must have felt insane to him, because he was sitting there in an emergency department, and you just have the curtains between all the beds. So he said he's sitting there and he's hearing the person to his left, the person to his right, someone else describing similar, like, neurological adverse events, all of them saying that it happened soon after the vaccine. And then, of course, this man was in rehab, couldn't walk for 6 months. And he said in the ward that he was sitting in, 4 out of the 6 people within the ward had all had their injuries come on soon after vaccination. So he's like, looking at it, it's fairly plain that there has been this increase in adverse events that have come on at the same time at the peak of the vaccine rollout. And yet it was this topic that couldn't be discussed. And he obviously carried that with him. And so I just, I guess our role is to just reassure patients, no, here's the TGA, DAN database, here's where we put in an event. The only way that we gather this information on adverse events is if we are recording them, and try to reassure that's what's happening. But I think that fear has been an extremely strong force throughout all of this.
But it's just come to the point where the silence is just deafening. It's just mind-boggling. It's such a major problem. We have discussions about the mental health epidemic, various other epidemics of ADHD, a lot of other cancers. There's open discussion about other medical conditions, but not vaccine reactions. And I find it's mind-boggling that it could be quite as long as it did. And I think the other thing is, apart from the fear instigated to doctors, is also the media silence. So when they report it, they make it sound like it's a very rare event, but I don't think it's rare. It's rarely reported. So everyone feels it's like they're isolated. They have a reaction. No one wants to know about it. So in 2021, you're mandated to have this injection. Once someone had a reaction, everyone wipes their hands clean of them. That's what I've noticed. They're all on their own then. And I think it comes back to the principles, medicine, first do no harm. It's always safety first. So even if COVID got risks among elderly people, no doubt, but then there's also the risks of the vaccination. Now, I'm not telling people to get vaccinated or not to get vaccinated, because it's their choice, but it's that safety first. So even if it's a very effective against preventing COVID or reducing the severity of the symptoms of COVID, you also got to look at, you don't want to make them get a heart attack or myocarditis and recover from COVID. So that's that, once again, the first do no harm, one of the fundamentals of medicine. And it's always safety first. So in any other condition, you worked in hospitals before, right? You worked in your GP practice. You always asked to speak up for safety. Our press motto is public safety. And the fact that we can't speak up, we're not against vaccination. I'm not against any particular thing. I have an open mind about things, but when I see dangers, when I see adverse effects, I feel I have the obligation to speak up, but we're being silenced by just expressing what we've seen. We're not automatically saying it's injections. We're saying this is what we're noticing after the injections. And the only common factor, it's not the injection, what else could it be? So, let's have the discussion, but no one's coming to say, well, what else could it be? They're all saying it's COVID, but not all these people had COVID.
Exactly.
And some of them didn't have COVID. They had the injections. They had these reactions, which I talked about, and they might have had COVID later. So you can't say their reactions are due to COVID infection either. So I found it very distressing. The hardest thing is the isolation I felt, not being able to speak out, being in my own little world, thinking, am I the one with the problem?
Yes.
Noticing all these things.
Yeah. I agree. It feels at times just very isolating because there's just such overwhelming messaging, as you say, in the media, amongst colleagues, suggesting that there are no safety events, and if they're there, they're coincidental or due to COVID, exactly as you said. And I agree. It's well past time where we should all just be able to be comfortable with having that open discussion. And I think where we should all be taking the same position that you've taken, where safety is first and our patient care is first, and that because that is of course part of our code of conduct as well, is that our patients have the right to their own healthcare decisions, and that we have a responsibility to respect our patients' decisions, and to our role really is to provide them with accurate information in an unbiased way. And that's exactly what you've done, and that's exactly the stance that you're taking. And it's just unfortunate that I think somewhere along the line we've forgotten that, or maybe we've put that secondary to this fear of COVID or something. But it's what we need to be doing.
Yes, I agree. So to safety, as I said, APRA exists. That's one of the reasons the national law was set up. When you look at the law, it's to protect the public. They're not protecting the public.
Exactly. And I think also we haven't had the accurate information to know that risk benefit for the public either. Like just before, when you were mentioning the risks and benefits to the elderly, that was something that really bothered me, because I noticed quite a few of my elderly patients who I'd known from a long time. I've had more patients die in the last 18 months than ever before. And this is amongst a cohort of patients that, you know, I've known for the past sort of 10 years. I've known them for a long time. And you start to see patterns of even staff members mentioning, oh, like my grandmother died soon after the vaccine, or my auntie died, and you just hear report after report. And then nursing home workers mentioning the worrying pattern that they were seeing in the nursing home, that elderly patients who had been stable and long-term nursing home residents dying soon after having the vaccine. And so I don't know that we ever were really given, I think, the correct information to be able to recognise those risks and mitigate them, because the quoted risk for COVID in the public is about 2 in 10,000, the sort of case fatality rate. That's across the population. But if you're over the age of 65, it's 1 in 100. So it's not a small risk from COVID. There's a risk there. But I requested under Freedom of Information the data from the Norway nursing home deaths that were reported early on, where we were just reassured that had nothing to do with the vaccine, and there was no risk to the elderly. And I was just, to be honest, quite appalled when I got back the Freedom of Information documents that I requested, because in fact, what the Norway regulator made changes to the approvals in the elderly. There was email communications between John Skerritt and Jane Cook, who was the CMO for the TGA at the time, where they all acknowledged that 1 in 1,000 elderly people had died, and that from the vaccine, and that the reason that they died is that they were frail, and the vaccine had such a sort of systemic reaction that they got nausea or became dehydrated, went into renal failure and died. So there was a clear mechanism for how this 1 in 1,000 had died after the vaccine. And of course, that's still less than 1 in 100. So if all of them had have caught COVID, maybe their benefit still from the vaccine, perhaps that might have outweighed the risk. But just the fact that wasn't disclosed, that wasn't in the product information, because if we'd known that, we could have made sure that the elderly residents were well hydrated, that they had good renal function at the time of giving the vaccine, and mitigated the risk of some of those deaths in our elderly patients who we were meant to be protecting. So I just think it wasn't just fear in some ways, although I think that was by far it's been by far one of the biggest factors that stopped open, correct scientific discussion about all of this. But it's also been incorrect information. I think we've been working on almost widely at a basis of a very inflated risk of COVID and death from COVID versus this just sort of minuscule, rare and mild, risks from the vaccine when that's not the case.
Correct.
And
one other thing I was going to bring up is the violation of consent. Something else that really troubled me was the right for someone to say no. No is a complete sentence. Doesn't matter this injection's been around for 100 years or 1 year. It's a basic medical principle. We don't judge our patients. We give them the information. Sometimes we think they're making the wrong decision, when they decline certain potentially life-saving treatments. We've all seen that. And the patient says, like, for example, specific cancer treatments, which the patient doesn't decline, sorry. And then they might face the consequences of that later, but we leave it to them. We just advise them. We say, well, we documented, we advised this treatment, but we don't mandate things. We don't force things. We don't treat them any differently because they refused a specific treatment. So it's this violation of bodily consent, the right for people to say no. It doesn't matter how effective or not effective it is. It's just a principle. We don't want it. No is a complete sentence. And now there's a lot of gaslighting now. Everyone's now saying no one forced you to take it. Have you seen that going around?
Yes.
That's not true. We know that's not true.
Yeah, that's absolutely not true. Yeah, I like that. No is a complete sentence. I agree, Shoba, and I don't understand why why more doctors haven't taken issue with this, because I mean, you literally almost just quoted our code of good medical conduct there, because it is an obligation under our code that we respect our patients' right to their own healthcare decisions, that we do not discriminate if the choices that they make have contributed to I can't remember precisely how it's worded, but if the patient's choice has contributed to their health outcome. So that's meaning that we don't treat a person differently because they smoke or because they drink or because they engage in any other sort of risky behavior. If they don't wear a mask, if they don't take a vaccine, none of that is meant to come into our clinical care for our patients. And I feel like, I agree. I feel like we've just stepped away from our own code of conduct and code of ethics. And I don't understand why more doctors haven't found that problematic for our patients. I found that really difficult.
100%. Was there in Queensland, like a lot of doctor practices in Adelaide, it's all not done anymore, but in 2021, 2022, you'd have to produce your vaccination certificate before you saw the doctor. And if you didn't, then you just get a phone consultation. You'd be sitting in the car park. So all of that is like a clear breach of our medical ethics. So there's so many instances. Look, it's all very disappointing. I think we've lost our way, as doctors lost our way. We've got to win back the trust of our patients. So I think it's the fear, once again, the fear of COVID, that everyone's sort of doctors, humans, we also get, brainwashed by propaganda. So I think it's a large part of that fear of getting COVID that's driven a lot of these behaviors.
Yep, I think that's very true. I've never seen colleagues just generally as fearful ever before. And I think that was really driven by a lot of the early messaging. Like some of the first social media amongst doctor group posts and things that I recall were stories of doctors who were caring for patients and who died, or brought the virus home, their family member caught it and they died. So there was a very, very real fear that if you caught COVID, you would die, and that your chance of catching it if someone even walked into your clinic. And I remember looking at just in terms of like risk mitigation amongst my own practice, and we did some things that I think were good, and some things that I look back and think I wish we hadn't have done that. So I mean, we closed the doors so that everyone had to phone before they came in, and everyone had to be sort of screened in terms of their contact with COVID before they could come into the clinic, and we did a lot of phone consultations, and that's something that I look back on now and think, had I really understood now perhaps the risk benefit and how we can mitigate a respiratory illness and what the actual case fatality rate is, I would probably have been more concerned about the care of patients who weren't getting as good care because they weren't being physically examined when they needed to be. But of course, some of those first reports that came out from Italy was a case fatality rate of like 10% or something, 9-10%. And so, and yet it was interesting around that time when I was trying to mitigate that, and I bought air purifiers for every consult room and the waiting room, and we had like a side area where we could see people with viral illness and things like that. So I think all of that was so highly inflated, our risk that we would catch it, our risk that we would spread it, our risk that we would die from it. And then to add to that fear, that risk of APRA and all of the sanctions that go along with that. And when we were talking before about things like assessing for causality and how we determine, is this a coincidence? Is this causality? I was thinking about this a little the other day, where there was an interview or a debate, I guess, that was being held between the doctors on two sides, as I suppose we've been put. So a doctor who
mainstream side and
a so-called mainstream side, whereas I think mainstream should be scientific, rational discussion about safety issues, vigilant reporting of adverse events, and listening to our patients. To me, that's mainstream. But the mainstream view, as it's proposed now, seems to be more, well, the way it's being presented is that it's more about, well, mainstream means following along with official advice. But of course, that official advice might be wrong. That official advice might not being given by a specialist. It might be by a premier,
But even our official advice has changed so much. There's been no consistency. So initially, when you were in close contact with COVID, it was 2 weeks of isolation, then it was 1 week of isolation, then I think beginning of 2022, it was 5 days, and now there's no isolation period. So that keeps changing. So we have to trust sources to an extent, but we also got to question that information also keeps evolving as well. So we've got to keep up to date as well. So what you were talking about was a debate between Dr. Bay and a cardiologist. It was on Rumble. And what the cardiologist was saying is a lot of patients have always had weird illnesses, which we know about. Patients have always had unusual presentations, which we could find no definite cause for. What the mainstream doctor was saying was, now, because the COVID vaccination was mandated 2020, 2021, 2022, now people are blaming that there's a scapegoat. The vaccine was a scapegoat to blame the illnesses on. Now, that could be true just in some cases, but a lot of the patients are not stupid. They were healthy before. They take the injection, 2 weeks later or 1 week later, they get sick with a variety of issues, which we discussed: heart issues, neurological conditions, confusion in some of my older patients. So there was nothing else. And that's what you were talking about, the temporal relationship, which you wanted to go into detail about. So I disagree. I wonder if the mainstream doctors, the patients are shying away from, because they know they're going to be gaslighted, so they don't bother going to them, so they don't see the injuries. That could be one explanation. But I definitely don't agree that it's used as a scapegoat, because there's so many reactions, so many people speaking out, members of the public, that they all can't be lying. They all can't be saying, they all can't be coincidental.
Exactly.
And also the stats are bearing out. Like in America, there's this man called Edward Dowd, who wrote this book called Cause Unknown. The disability rate in America has gone up. Not sure about the statistics here. We know that excess deaths have gone up. Now, we don't know what the cause is, but clearly something is going on.
Exactly. I love that, Shoba. Our patients are not stupid. And you're absolutely right.
Yes. I mean, that's what we do. We listen to the patient. They may not be right. Sometimes they're not right. Sometimes they think a symptom is due to some other cause. But you do listen to them. And there's so many thousands saying that since the injection, the health has deteriorated. You have to listen.
Exactly.
Can't just say it's coincidental, which is what a lot of doctors are doing, which is very frustrating for the patient and for people who can't speak out, because if they do, they're going to be penalized or shut down. People like myself.
Exactly. And the thing is, I think the point that was being made by the doctor describing himself as a mainstream doctor was that these things have happened all the time without any explanation, like just as a matter of bad luck and chance. And that was actually exactly the response that I got from John Skerritt, the former head of the TGA, when I wrote to him about the reported death in a 14-year-old, a number of other deaths in teenagers due to cardiac arrest. And the response was, sadly, 150 young people, die suddenly every year. And so the idea is then, well, these things just occur suddenly. And so why are we blaming the vaccine for it, that we're now seeing things like sudden deaths and cardiac arrests? But the point is, you could say something had just been a rare, unexpected, sudden event if they hadn't had the vaccine. So then we would say, well, that is terrible luck. That does happen to, you know, one, which is roughly 1 in 10,000 young person might have, say, 1 in 10,000 to 1 in 100,000 risk that they may die suddenly and the cause is unknown. But if someone's had a vaccine days to weeks before that event, what is the logic where we would dismiss the vaccine as a potential cause simply because that event can happen without explanation? Sure,
it's got to be the differential diagnosis. You've actually got to at least put it in the differential diagnosis of potential causes for their presentation. Definitely.
It has to be considered a possibility at least. And again, that's our job, that's our role, that's a requirement of every one of the company sponsors within the TGA, like the post-marketing surveillance requirements, is that they are actively looking for these types of events. Whereas it seems like there's been an active effort to hide these types of events, or certainly not to discuss them. And I agree with you, in a lot of terrible instances, to gaslight patients who are suggesting that there might be a link.
That's right. And the patient's already suffering. They're already, I've heard that, you sure you have as well, going from doctor to doctor, trying to find an explanation for these symptoms. So the patient's already in distress. Don't distress them further by dismissing the injection as a cause. If the patient thinks so, you may not agree, but don't be insensitive to the patient. Because you want to protect your own career, or you're scared of the consequences of speaking out. I think, because in the end, we have to look after our patients. It's the patient. It's a patient-centric model. Now, it doesn't mean the patient is right or we are wrong or the other way around, but we've got to at least listen and take it seriously.
So true. And I think you're so right about the dynamic of the conversation, of a consultation, that relationship, the dynamic when the patient is already suffering from something that already would have all of that extra, like, emotional distress of, because a lot of them, even their own family and friends, don't want to hear about it. It's like their boss, who perhaps has mandated it, they certainly don't want to hear about it. Then you walk into a doctor's surgery, and if you even get a hint that doctor's going to mock you or roll their eyes or belittle you for saying that, you're not going to say another word. You're just going to sit there quietly and try to find a doctor who might help you. So I think you're right, Shoba, that a lot of doctors probably, if they're not asking, and if they're not asking in a way that allows the patient to raise their questions or their fears or their observations, you're not going to hear about those adverse events. So you probably are going to be coming from a perspective of, well, this is extremely rare. I'm not even seeing anybody talk about, I'm not hearing about it. I'm not seeing any patients with it. This is rare, and COVID is so serious. End of story.
That's right, because patients aren't telling you, they're not disclosing it to you.
Exactly. And I think we were given a lot of the, again, just the wrong information, even as doctors. I was just looking back the other day at one of the early ATAGI guidelines, and this was one that really bothered me a bit as well, because we had and it just made me think of it after watching that interview that we were just talking about, because one of the other arguments was to say, well, number one, myocarditis, for example, is very rare, according to this doctor, and that if someone contracts it, it's mild, it has a self-limiting course, and much less than the effects of COVID. And I think that's just so frustrating to hear that, and I can't even imagine the frustration that a patient who's had myocarditis or any of the reactions and are still suffering to this day, as I know many of them are, to hear someone dismiss it as being a mild illness. And
it's not mild to them. It's not. It might be mild from our sort of, we look at the blood pressure and listen to the heart, and we might label it or dub it as mild. It's not mild to them because they know the risks of myocarditis, risk of heart failure, risk of, increased mortality. Everyone knows that. You can never call it mild.
Exactly.
It's a contradiction in terms.
I agree. I think it is a contradiction in terms to label myocarditis at all as mild. And by definition, it's a serious event. It's whether, and I guess where I think this idea of mild is coming from has been this reassurance that there'll be a full recovery, that everyone recovers within a short period of time. And we heard that even by the heads of the TGA, by the health authorities, who would say maybe a small percentage might have to go to hospital, discharged the next day, monitored, back to life. And so then you've just got this train wreck of all these people who are not even close to being back to their life after months and months and months, and with ongoing symptoms. And what bothered me was that early on, so this would have been maybe September of 21, one of the early ATAGI guidelines had a paragraph on sort of prognosis and long-term follow-up. And I think some of the language that's used is part of what's perpetuated this idea that myocarditis is self-limiting, fully resolves in almost everybody, particularly very mild in children, and that children have a much more, mild disease course. And I think where this came from, and I'll just read it out, you might find this interesting, is that, so in the paragraph on prognosis, it stated, importantly, most people who've had myocarditis and or pericarditis due to other causes recover completely and have no ongoing impairment of cardiac function. Early data suggests this is likely for the causes with mRNA associated with mRNA COVID-19 vaccination. So in other words, every other cause for myocarditis is mild, they have a complete recovery. We think it's going to be the same from the vaccine. And then there was a reference that was attached to that, and reference 25, and that referred to a review. So it was acute myocarditis and pericarditis in children. So quite a large review that was done in 2019. And so at some point when I was just sort of trying to, well, it was after I had a couple of young people actually get myocarditis, and that it really upset me because they were required to have the vaccine to participate in, it was like an end of year, concert or a formal or something of that nature. And then they couldn't participate in it because
they got sick.
They got sick and they couldn't exercise. And it was actually very distressing. And I thought, oh, well, I've never seen a young person with myocarditis. Actually, in all the years, I've only had one patient with myocarditis that was after influenza, and that person actually had quite a long recovery. They did eventually recover their cardiac function, but they were in heart failure for a good year or so. So I thought, well, I don't actually know what is the outcome in children and adolescents. So I looked this up, and then I went to this reference 25, which was behind a paywall, which also just bothered me because, I think the government guidelines, you shouldn't have to search for the article that it's referencing. But I went to the article that it's referencing, and lo and behold, what this study reported was that in the multi-center cohort they were reporting on, that 13% of the young people who were diagnosed with myocarditis either underwent cardiac transplant or died during that initial ICU admission. So it's 13%.
The worrying statistic.
Absolutely insane. And then that same article, which was referenced in the ATAGI guideline and for which was meant to reassure us of how mild, limited long-term mortality, etc., that guideline then goes on to describe some of the other outcomes, where there's a type of myocarditis called giant cell myocarditis, median survival of less than 6 months without a cardiac transplant, and something like somewhere between 37 and 50% progress to transplant or heart failure within the next 5 years. So that was in fact what was, unless they've just included a reference that nobody actually bothered to sort of read, how on earth you would draw the conclusion or seek to reassure doctors that this disease was mild with a very, favorable long-term prognosis, when the evidence that you're providing to support that is horrific. You couldn't even, if you had a parent asking you, okay, well, what's the prognosis? What's the guideline? Imagine if you actually brought that reference up and showed that to that parent. That's horrific. And I think the public deserve to know that if that was what was known to the policy decision makers. And that just makes me outraged, to be honest.
It's outrageous.
Oh, so lovely to talk to you, Shoba. I think where to from here? Like, what any messages for me as a GP? Any messages for anyone who might watch this? What do you think's the answer here? What do you think we need to be doing next? How do we help our patients and our colleagues through this sort of next phase?
It's a good question. It's been a hard journey for myself as well, because for myself, it's been an awakening in a way, not in a good way either, because what I've learned in medical school, what I often accepted as dogma, I'm actually questioning everything I learned now. Any study I see, so in a way, it's been good because, of course, I follow the science, but I'm more skeptical about the design of the study. Is it accurate? All the research that I looked into before deciding a specific treatment for my patient. So I'm a lot more cynical, a lot more skeptical. Maybe that's a good thing because I don't always take everything at face value. I do a bit more research now. That's what it's taught me. So in response to what you're asking, I would say more doctors need to speak up. It's almost like it's too late. It's 2 years down the line. I mean, you look at all the hospitals, they're all completely full. As you said, could be a lot of injured patients. I reckon people have been silent for too long. And I think if like 1,000 doctors stood up and said, well, of course, if they're seeing what you and I are seeing, and they stood up, they can't all be dismissed. They can't all be deregistered because they have a strong voice. I think one of the things lacking is the lack of unity and the sort of also the gaslighting of doctors by their profession as well, being shut down. I've been shut down. I've been mocked. I'm not an anti-vaxxer. I'm not anti or for anything. I'm just for the patient's benefit, for the patient's safety. So I would say speak up, get solidarity with your colleagues. So not everyone agrees with me and you, and that's fine because they might have seen a different picture. Maybe they're not seeing anything, and that's true too, because I'm sure some people are not seeing anything from the injections. But if you are, I would say speak up. Either write to your MP or politicians to keep them accountable. But I think the main thing is to speak up with other doctors. So they're kind of solidarity and say, we're actually seeing all these things. And we're not 100% sure what the cause is, but we actually have to say that the vaccine is one of the differential diagnoses of why so many people are suffering with these health issues like I described. So I'd say that, speak out. And I think you've got to look at yourself 10 years from now. I think this is all going to fall apart. More and more truth is coming out. We don't know the long-term effects. I'm seeing this cognitive decline, which is very worrying among people, younger and younger people. So to sort of take that further to doctors, if you know something now, speak out or at least share your views, get them out saying, I'm seeing these things. Are you seeing these things as well? Because in 10 years, you're going to feel terrible. You didn't do anything. You didn't do anything. You didn't speak out. You didn't defend your patients. But that's what we're there for in the end. We're here to make a living, obviously, but our first concern is patient safety beyond everything else. So my message is to speak out, get over the fear. If you're seeing what me and Melissa are seeing.
That's brilliant. Such an important message. And you're right, our first concern must be the care of our patients and nothing else, whatever consequences we might have. I think one of my patients put it best where she said, I can understand that the doctor that she'd been seeing previously couldn't or wouldn't talk about the vaccine. She's like, you guys work hard for your careers, you study for a long time. But she said, I've lost my career too. I'll never work again. And I think we need to put that into perspective, that our patients who have been injured have lost so much, and that our first concern has to be care for them. And I think you're right. On the one hand, it feels like this has gone on far too long. And, is it too late to help these patients? And is it too late to mitigate some of the harm? But I agree with you. I think there's still a huge need to speak out at this point. Regardless of, I guess, what's happened throughout this first, the mandates, the COVID vaccination program, the harm that's come from that, we know that the direction that vaccination is heading in and other medications is the use of the mRNA platform, which I would argue, we haven't had the opportunity to gather enough safety data on that. We've got 4 mRNA factories being built in Australia as we speak. And the figures that are reported in the media is sort of 400 million doses per year. Well, that's 20 per person or something. I mean,
26 million people, so that's a lot
yeah,
of doses per
that's a lot of
person.
doses. We're talking like 15 per person per year. So presumably this is a platform that's going to be used for the future in medicine. And we know there's already trials on RSV vaccine, influenza vaccine, and the mRNA platform to be used in a number of cancer therapeutics. So I agree with you. It is just as important that we are vigilant in reporting adverse events and speaking out now, because if there are some inherent risks to this platform, we're going to continue to see harm. And so even though it is late and so many people have already been harmed, that there is an opportunity to really, us as a profession, demand of the regulator and demand of the officials that these safety issues are evaluated moving forwards.
Yeah, as I see it, it's a big elephant in the room. The elephant's getting bigger by the day. But talking about the vaccine injuries, long and short term, short and long term. So yes, it's late. It's 2 years down the track, but it's come this way because everyone's been silent. So we at least acknowledge this is a big problem, right? Okay, we were wrong. This is a big problem. What can we do to help these injured people? More research into what the mechanisms are on how the injuries are caused, for instance. And now, like in America, there's have you heard of FLCCC? There's a
Yes.
protocol to treat vaccine injured patients. I think that's the next step, to speak out, acknowledge the problem. Now, how do we treat the problem? So yes, it's probably not worth looking back. Moving forward, this is like, let's do it. Let's be more honest. Let's be more united with other doctors. So that's what I would say.
I love that. Yeah. And coming up with protocols. There's FLCCC, and there was recently the first peer-reviewed paper on what they call spike-related pathology. So that paper covered spike pathology from the virus as well as vaccination, and for the first time in the peer-reviewed published literature really discussed some of those mechanisms for the vaccination injuries, because you're right, we don't actually even know how a lot of these injuries occur. So then how on earth do we ever start helping come up with protocols and research and ideas that might actually help patients who have had these adverse events? So I love that. I think that is exactly the next direction that we need to take. Fantastic. Thank you so much for the chat, Shoba. It's lovely to speak to you. I can't wait to meet in person one day, and good on you, and good luck with everything that you're doing.
Oh, thank you very much for having me on, Melissa. It's just such a great chat.
Thank you so much. Take care.
Okay.